I'm going to invite Dr. Ben, who we haven't heard from yet, and everybody else you've heard from and are aware of. And Dr. Ben is a medical oncologist specializing in breast at West. All right. Thank you, guys. Look at that. So cozy. All right. First question, I'm going to Jordan.
Oh, okay.
Since you're
on a roll already. Yeah.
You're on a roll, let's just do
Okay,
it.
I'm ready.
So, dealing with not necessarily oncologists, because you deal with the gyne group, radiology group.
Everybody.
Everybody.
Yep.
What do you think is the biggest gap in communication and or coordination that creates delays and efficiencies in care?
Exhaustion, fatigue on the part of our providers, right? I actually really do think that's it. I think it's that the ability to really be present in that communication is a huge deficit that we have, right? So just like we talked about briefly, what impacts all of our patients, all of our providers have all that happening in the background too, right? And especially when we're talking about trainees who are working, a bajillion hours a week, I think that we just have very little intentionality in that communication. We come in with what we want, what we think needs to happen, why we think it's a problem. And then we would really like somebody else to then just say, okay, fix it. So I think that, intentionality is the best thing that we can do in those communications, which is to say, like, again, with the pause, right? Like, why am I actually here? How can I move this forward? And then I also think that there's a factor of busyness, right? So you make that first call, you say, this is what we need to do for this patient. And then you go see 20 patients in your clinic. And it's at 5 p.m. that you actually come back to that. So how do we have our ancillary staff be part of that follow-up process so that we have a shorter response time to things in the interim? So like you start something at the beginning of your day, you go do your whole day, and then you come back to it at the end. Now that's a whole day lost for that patient. So how do we leverage our other staff to say, okay, I have started this. Can you follow up on it at X time so that we have, again, more intentional timelining?
Anybody else want to comment on that?
So many levels to that. Even just from the patient in terms of even understanding how quickly some things have to happen. And then like what Dr. Muaiad pointed to in terms of the communications with the primary care providers, them being able to get the patients in, the ancillary care, making sure at West, we've tried to, if it's an oncology case, we've tried to get them in within a certain timeline. And so I think that has made a major difference. So they're waiting 2 weeks to be seen. And then it's another 2 weeks to send their tissue off. And so I think from that level, and then what she just alluded to was also the ancillary care, and so when you put the order in for the next phase to happen, that has to be sped up. My pod tends to keep lists. So we come back and we follow up on that. Has this been done? Or we just send messages. Hey guys, this is a quicker order than, colonoscopy that's needed later. So there's just so many levels to that in terms of delays potential.
Yeah. So thank you. And I agree with the comment. Switching roles for a little bit, questions for a little bit. We do have a lot of screening tools, some of which have guideline support. And in recent times, we have more technology, like methylation-based technologies that are trying to screen and allow for early detection. What sort of technologies are out there that you think will impact what we do in the future? And then what are the issues with getting them implemented? So that's one question. And then, Porter, I need you to talk specifically about lung cancer screening. because it's a tool that's out there and it's been out there, but it's very underutilized. So the first is the new technologies out there that helps us screen our patients and get them through to our care and what are the issues with them, and then the lung cancer.
Jump in on this if I can.
Yes.
So, technologies are a means to an ends. And if you don't have the ends in mind, there's going to be lots of different technologies out there trying to solve piecemeal things. And then you get technology bloat where there's 17 different prompt tools interfacing with your EMR or tabs that you've got open, each doing their independent thing that you feel like, your HR department or your CMO or somebody's pushing on you. And then you're saying, well, I'm doing all these things. I don't even have time to actually have that handoff call with my own staff. So one thing that I think, regardless of what the capabilities of technology are, which I think are tremendous, I think that one of the things that we need to really respect and think about, both in terms of how payers and hospital systems and people think about cancer care, are as a bundle and as an entire cancer continuum of a journey. From the moment that you suspect somebody has a cancer all the way until their fifth line or whatever it is, or their survivorship. And if you build a technology platform where everybody in that pipeline that has a touch point with that patient is knowing how to use that same platform together. I've thought we don't take AI things, but 30 years ago, even if we're using a paper chart for social determinants of health screening, if we simply made sure, if we walked to some primary care office and said, why don't you use the same paper form that we use? And then that way, when you get these things, we'll be able to compare and contrast or integrate it. I mean, that's a low tech solution, but it's just making sure that people are on the same page during the cancer care journey. So I think technology gives us all these amazing opportunities to think about the next way to level up these problems in communication. But if we're not then applying those in a way where, especially even patient-centered way with health literacy issues, English as second language issues, just digital literacy issues, they're going to be really not designed in a way where they could be implemented with the outcomes and the efficacy that we deserve.
I agree with everything that you said. It's a combination of technology, communication, and collaboration. That's what we all need. You mentioned technologies such as using methylation. We know the Gallery test is already available, marketed in some states for early detection of cancer. We also know that, artificial intelligence technology, but is available. And there's so many other tests. If you go, you and I were talking about the AACR, and this coming AACR, you see how much, AI technology is available. But but a lot of these technologies, they don't interface. That's part of the technology itself. You have different softwares, different applications. How do you interface all these softwares in a patient-centric way? And how do we all collectively collaborate and communicate to make sure all this technology is being used to serve the patients first, from the beginning of screening to cancer, from early diagnosis, early detection, to finding biomarkers that are actionable, whether it is, in the early stages in terms of, how to make treatment decisions, to the continuum of follow-up after the patients are on surveillance after their cancer is cured, between, all this being done by oncologists, primary care physicians, and multidisciplinary teams.
Yeah, one of the issues with our technology, and there are different companies out there, it is so siloed that everybody is just focused on their part, that it's hard to find something that just brings them all together.
And competitive rather than collaborative. Unfortunately, that's where I
they're
said
competitive. That's correct.
Mm-hmm.
Go ahead.
We well technology. You're picked.
You're right.
Fine.
You're right. Very important point. Anybody want to take that?
Honestly, when I said communication, when I meant communication, it's not communication. What I meant, not only communication between the technologies and the platform being able to communicate with each other. That's a completely different challenge than the interpersonal and the human communication issue. And that, yes, definitely. And
nurse, agencies, right? Lower time.
right.
That version of
Right. Yeah.
are not on the same plane. They talented.
Totally agree.
I think that there's a huge, let's be honest about what the incentives are in healthcare system, to create operationally efficient, what we think are efficiencies, not necessarily need as many staff members. If we can use things that are automated, if there can be prompts, instead of having an individual have to call somebody for their follow-up, if it gets pushed through a text. There are a lot of these platforms and things that are built out with the idea of increasing productivity and increasing efficiencies. And I would say there's cynical side of it is to make more money. On the non-cynical side of it is when we're feeling like we're time burdened and we're stretched thin and we're thinking that there's not enough manual hours to do these tasks, there's a great carrot to say, if there's a technology that can allow us to not have to spend our emotional and mental capacities doing that thing, but the person who's not involved on what is the emotional and mental capacity being involved is the patient, right? So a lot of these things is who is the end user, and a lot of things that we're developing for operational efficiencies in healthcare are actually just shifting our provider tasks or our team-based tasks onto patient-centered tasks and actually creating greater barriers for individual patients while making it look like it's easier for the healthcare system side of it. So that's a huge concern, that there are, plenty of brilliant people that are focused on that. But whether we know those things from theory and whether as the business of medicine is going to gravitate to choosing those types of products is another thing to left to be said.
Right. So thank you. So Porter, do you want to comment on that conversation?
I want to say quickly, so the next step from that, simply in our clinical care is to find out where that patient is. Can you even read?
Yes.
And with these simple questions that we can ask the patient, and then it helps us from the equity standpoint to say, okay, this patient can read, this patient cannot. This patient is going to need somebody to call them in their follow-up and help them through these things. This patient is going to have access to an iPad and they can do it all on their own. And then we really kind of help to even the playing field.
Thank you. Yes, go ahead.
Like refer, and then he would be so helped by guys, they neuro progress no better, and that allows me to read. So I can know what's going on with the patient. So when the patient comes back to me, because a lot of times they may not follow, it may be months before they follow up with you. And then if I get the report and they come to see me, then I can go over that. And it just helps with the continuity of care. And so that's one of the things that I lack in primary care.
Thank you.
That's a big issue and concern for primary care. We don't get the progress notes back to know what's going on with the patient.
So with technology now, like EMR, at the end of our note, there is a box that you can tick to for the physician you want that note to go to. So one of the things I always try to do is make sure the primary care is there. I take that box when I'm done and I sign my note. It is supposed to fax you the updated information, which is very helpful. But not everybody gets it done. Do you have another comment? Or Meg had a comment over there.
And Dr. Ben, I'm not saying you don't do that. I just use you as an example.
She needs to know better.
Let's take a pause.
Yeah. I get your notes.
I imagine it's going to be the same for you. Like that.
However, I just want to relay more in a study of vascular ACCC, over 160 patients that were missing their follow-up visits for oncology, which we know is extremely important. And they didn't have enough staff. And the study was about nurse spots calling to remind the patient to set up another visit. And what they found was that patients were more likely to tell the nurse spot. And you know it's a nurse spot. It says, I'm a nurse so-and-so and AI technology. They're more likely to tell a nurse spot why they missed the visit.
Stand the person?
Might not. And regardless of age, people were using the chat. So it's a phone call, right? To your point, Dr. Ford, if you can't read, still make a phone call.
Yeah.
The last one, then I'll give it up. Thrive Link speaks to your social drivers of health. We had a conversation at the break. Thrive Link just won an award, and this is an AI technology used at Boston Medical for their patients. If a patient can't pay their electric bill, they can call this Thrive Link. Because they're in the system in the hospital already, all they have to say is, this is what I need. The AI completes the paperwork for them, submits it, and they get a bill in the mail. So I see the use for, if we could do more of that. And they had been less than a year, they'd already given $50,000 worth of money to people who needed it for social drivers of health. So I can just see a glimpse of what this can look like if we could do it. Even sorry, I'll let you talk. I can keep going.
Yeah, I just wanted to give Dr. Porter some credit, and where I think this really needs to go is it starts with asking the patient those questions, and also making sure that the questions are framed in a way where an answer is going to change what you do for them. We have so many surveys and so many forms that might ask a 20-year-old, when was your last colonoscopy? Or, someone else like an 86-year-old, I don't know. There's so many questions on these forms that are not only duplicative, but not even relevant. And yet we don't have forms. I bring this up as a joke. Our company said, yeah, we have a section where we ask, what is your preferred language? And I looked at it, and what they had looked like, you were going to college and studying languages. It was French, Italian, German. I'm like, these aren't the languages spoken in Middle Tennessee. I was like, so instead of actually identifying what languages you need for interpretation services and things like that, all the actual languages just get put as other, and we don't even know our own population. And so you think you're asking the question, but unless you're really asking it in a way where the answer is informing you on how you're going to help the patient, and then allowing for, I think what also was brought up here is choice. It's not one size fits all. So if we're not asking about things like health literacy, these matter. You can lump them in as social determinants of health, health-related social needs, and say that this is all woke stuff. But I like to strip it down and say, no, this is helping me provide more patient-centered and effective care for my patient. And we're not asking so many questions that if we just thought about it, would actually, maybe we don't have the resource today, but at least we know that there should be, or there could be a resource available to them, while we're asking so many other bloated questions because we're just supposed to check the boxes, which is actually kind of demoralizing for our staff and our patients.
Yeah, thank you.
I think the breaking.
I have to be honest, for sure. These days, is they're quite sick of doing surveys every time they go to the doctor.
Yeah.
So for us to collect data,
I think everybody's bringing a very important point here, which is patient voice.
yeah.
So it should be part of everything that we do, from hospitals, administrative work that we ask the patients to fill. If the patients looked at these forms early on to see what they're being asked and were involved in drafting, these forms, and the same thing applicable also for clinical trials, involving patients' voice in clinical trials is extremely important. That's what matters at the end of the day.
And so I would also add that many of these forms, if we use technology to help, we could send it to the patient like a week before. They don't have to be like in clinic when they're checking in and doing all this paperwork. And that usually is very helpful to reduce the burden. Dr. Porter.
So patient voice is a perfect segue into lung cancer and the screening.
Yes.
That question you asked. And then the reason why so much is lacking in lung cancer compared to some other tumors is there is no patient voice. Before recently, these patients didn't survive. And so now we're starting to have long-term survivors of lung cancer, and we see better outcomes for those patients. And so there will be a voice eventually. But right now, the voice is mute. There's nobody to advocate for those patients. They pass away. My dad passed away 20 years ago. Nobody's running around except that I'm working on starting a foundation called James Lee. In case you want to know about that, we can talk about it later. But that brings back a voice to somebody who's long gone. And these patients look very different from breast cancer and colon cancer patients. A lung cancer patient is short of breath. They're not out in the public. They're not going around doing all of these activities and going to, the fight on. They're short of breath. They're sitting in a wheelchair somewhere. They're at home. They are on oxygen. They're on high flow oxygen and can't come from home. They don't have a voice. And so as we get a voice and we detect earlier and have better adjuvant therapies and these patients survive longer, then we'll start to hear a voice and then we'll get over some of the stigma because there's no screening for a 40-year-old female for lung cancer right now. When we see a rising demographic of patients dying from this cancer and being diagnosed with this cancer, my youngest patient is 26. And so we have these patients now who are going to need a voice and we'll start to hear from in the years to come, which is exciting. And then we'll see that we should be screening. I say it all the time at these meetings. Who in here wouldn't want a CT scan? You don't have to be probed. You don't have to be squeezed. You just lay on the table. It takes 30 seconds. There's no IV. You don't have to be stuck. You just go in and out and we know an answer. So why would anybody say no to that? So we'll see an increase in screening later as we develop a voice for the lung cancer patients who will be surviving where they weren't before.
So why isn't everybody getting the low-dose CT scan?
It's the guidelines, and with those guidelines, they will eventually change because I guarantee you, I'm going to talk to my 51-year-old patient with a stage 1 breast cancer who also had a concomitant stage 1 lung cancer. And I'm going to tell her, as you survive with your ALK-positive lung cancer for the next 20 years, make sure you yell about it and scream about it that you wouldn't have been diagnosed because you didn't smoke. Nobody was going to look for it. And so as we start to educate these younger patients, then over time, the stigma will go away.
But it's going to take a couple things to add on about that, like just moving the needles. One is I alluded to the fact that we're focused on breast and cervical because there is the National Breast and Cervical Cancer Early Detection Program. But really advocating for policies to say, if there's a screening test for a lung cancer that is overall survival, even hepatic ultrasounds for people with cirrhosis, and colonoscopy, why are they not bundled in as a part of the early cancer detection program? If there's no reason why somebody should sit there having blood in their stool or coughing up blood or feeling like they can't breathe, and there's no program in place for those people to figure out whether they have cancer. Could that help move the needle? Similarly, if we think about these things in terms of bundle sets, could there actually be some cost savings and convenience for patients to think about the totality of your cancer screenings? That if you're showing up for the squeeze, you also get that CT scan. And if you do it the same day, and again, patient choice, maybe you don't want to do it all the same day. Maybe you're very overwhelmed. Maybe there's good reasons, and it's actually easier for you to drive back a second or a third time. But you give that choice. And if we can bundle set these things, knock them all out at the same time, maybe that's easier for providers to navigate. Maybe that's easier for patients. Maybe bundling that together creates less cost too, in terms of figuring out where the locations and the facilities where we have to do these things. There's a lot that I think we could think about creatively if we think about these things in terms of bundling them together.
So on the policy perspective, I know a lot of what we do is influenced by laws, rules. If you were to speak to a policymaker and they asked you, what do you think is the most important, and I'm assuming you all may have different perspectives, policy change that could be made to impact disparities in health and outcome, what do you think that would be from your perspective? Any one of you?
I have an idea about a diagnosis code. About a diagnosis code that I think could knock a lot of it out. I love bundling. And I called it, the diagnosis code DXX.X. And if you put in that diagnosis code, your screening for whatever cancer you want is approved. Or your PET scan, your biopsy, your NGS. If you have this particular diagnosis code, what that diagnosis code is conveying is that clinician feels like the risk and suspicion for cancer is so high that there shouldn't be any barriers to do whatever you need to do next, because if you do, that patient's outcome is compromised. And so with that particular diagnosis code, if I want to order blood, NGS, and tissue, even though the biopsy is not ordered yet or it's ordered at the same time, it can all still be approved. The PET scan, the MRI brain, it can all still be approved under this particular diagnosis code, because that diagnosis code means that that provider is saying, I feel like this patient is at risk if I don't move fast. And so with a situation like that, now, if you come back to find out that there was really no suspicion, then the provider should feel, obligated to justify why they used that. So I have a, 19-year-old that I saw in clinic with a 11 centimeter hepatic mass. That's not lung cancer, I know. But my residency program director called me on the phone and I wasn't going to say no. So I brought that patient in and I started the workup and sent him to the hospital because his LFTs were rising at a really rapid rate. And they denied the hospital coverage, in which I was expediting his biopsy because I knew it was going to take 3 weeks as an outpatient. I shouldn't have to justify that. I have clinical documentation that he was at risk, and now they're denying the hospitalization when really it was justified. So I feel like if we do that, we may be able to level all of this out and move patients through our system a little bit faster, even if it means bringing them into the hospital and knowing that it's going to be covered.
So let me play devil's advocate here on the payer side. I can foresee potential abuse of that system because it has to be painful. So how do you police?
Right. So we do audits all the time. And I feel like that, like I just said, the provider will need to show justification. And on the back end, if you can't justify it, you may be held liable for it. So if I'm sending a patient to the hospital going, hey, I know you don't really need this, but I'm going to send you let's just get it done. So, let's be honest. Who wouldn't do that for their brother or sister in this audience,
Right.
So you would, but if there really is an urgency, and I know from a lung cancer perspective, I got a 10 centimeter mass that's obstructing the left mainstem bronchus and that patient is going down quickly, I need to move them in. I can't send you to see a pulmonologist and expect that they're going to see you 2 weeks later and then schedule your procedure in another week. You're going to die. It's a little bit different tumor type because this is an essential organ. So for those situations, again, where I show justification, and if I get audited and they come back and say, now you put this patient in the hospital with a 1 centimeter lung nodule and there was no urgency, you're held responsible. So there should be some audits on the back end.
I do think, as far as what those justifications could look like in linking codes, people with what you think at best medical guess, clinical stage 3, advanced stage 3, right? People with concurring oncology emergencies, those types of things. You could say this is not just somebody that has suspected lung cancer, but they have SVC syndrome, they have a spinal cord compression, they have, X, Y, or Z. I think if you were to say that and say this is just a needs expedited workup because of these health emergencies, those things, that's why those codes exist, right? Is to say and hospital billing gets to upbill for your bundled, per diem or however they make their arrangements. And they're always saying, make sure that it's acute on chronic heart failure with an exacerbation, or that it's both hypercapnia and hypoxia with the respiratory, because, they're going to figure out what the ultimate flat rate billing code for that hospital stay is. And you need to upcode to make sure, and it's not to cheat it. It's to say that really was the complexity of this patient. So I think there are similar things to say there's a complex patient here. I don't know. I think it's open to thinking about it.
So non-physician on the panel, do you have an opinion?
Oh gosh, I have so many thoughts. I think, what I'm thinking about a lot when you all are talking about this is you're talking about how you think there should be, early universal screening for, a low-dose CT scan for everybody, right? There are people who are getting that in this world, right? There are people who are connected, who know your residency program director and who call you, right? They're my own personal health, right? I know how to navigate the system so I can get more screening. And when I read down on my mammogram results and they say, it's not within the guidelines to have breast ultrasound, but for patients who desire additional screening, right? And I'm like, yes, please. Yeah, I'll take it, right? So there are people who are already getting that level of care. And that, I think, hugely impacts when we're talking about why do we have these disparate outcomes for patients. That's why, right? Because some people have access and medical literacy and connectedness, right? You know, if I have a medical problem or my family has a medical problem, I know 500 doctors to call, right? And I've spent a lot of time building goodwill with them so that they're willing to help me when that comes up, right? That's actually the only reason that I do this work is, you know, for access. But to your question about like policy or systemic change, I know we are in a room of a lot of oncology specific providers, but I also know we have some primary care here as well. I think elevating the practice of primary care is what would help with this system navigation. So if you've had a great primary care provider in your life, you love them, right? Like you think so highly of this person. Or even if you're really well connected, like myself or anybody else probably on this panel, I've probably had 5 PCPs in the last year because they keep leaving and they keep, you know, and they're at Stanford, so they keep getting involved in whatever other project and they're going to whatever. But that's why people are paying for concierge medicine now, is because they want that connection with their PCP. I think if we could elevate primary care practice, we would have immensely different, what's the word I'm looking for? Advocacy for our patients. So when you're talking about like, if I have this diagnosis code, not only do I justify it, but that person's PCP also justifies it because they've been watching them crumb for the last 6 months, right? And have been trying to figure it out. So if we could, and I mean, the way that we elevate that practice is by compensating it, right? Is by providing additional ancillary staff in those places so that we can really free up the physicians and the providers to spend more time with the patients and to do that advocacy communication. Like, what would it mean if the PCP and the oncologist actually spoke on the phone to each other, much less like met in person, which would be incredible. And then we could talk about like levels of care in the same place. But what would actually happen if you as the PCP called and spoke not to somebody in their clinic, but to the oncologist themselves and said, I have known this patient for 10 years. I know their family history backward and forward. I know their social determinants of health. I know why this is hard. And I think that they need to be seen immediately. And I think this is what needs to happen. Like, that would be incredible. We don't have the time for that is the problem, right? And again, when we talk about time savings versus time suck, we think it's going to be a huge time suck. But if an oncologist and a PCP could have an actual conversation, that would be huge. So all of that, when we talk about big systemic change in oncology, I think we also need to talk about how do we elevate the practice of primary care and create those relationships between patients and their providers? Because we're constantly referring back to them. We're like, hey, take this form to your PCP, right? Yes, right? Absolutely. Oh yeah, nobody here signs that. You should follow up with your PCP. Make sure you make an appointment with your PCP, right? We talked about this, you know, like, you talking about like, we screened for something random, you know, when was your last colonoscopy? Oh, you should talk to your PCP about that, right? Like, we need for that person to actually have the time and the investment and the positive regard from our specialty care providers to help advocate for that patient and to get them that diagnosis code so that they can get, you know, what they need in an expedited fashion.
Thank you. There's a question, but it's probably more of a comment. Go ahead. Mm-hmm.
Well, amen to that. I'm the immediate past president, and one of the things that I hope to be my legacy from that is last year we decided not all of these things should be on the president to execute, but let's create some subcommittees based around kind of our key objectives. So we have now one on education, one on advocacy, and another one on outreach, which is actually what got us into Memphis last February to meet some of the crew out here and to build those pipelines together. But what I'm really excited about, and what I'm still trying to pitch to my board as now not having the muscle as president, is a TOPS grassroots. So it's one thing, we have a lobbyist that we've had that works on Capitol Hill with us and helps us put bills together, but patient stories, provider stories, primary care, that multidisciplinary care team, to figure out where are the issues that we need to work on this together, not just medical oncology carve outs, but thinking about that whole continuum, whether that's Medicaid expansion, all kinds of different things at the table to say, do we need to be a voice of? We're trying to develop that group, create an easy button. That we do have a couple bills that we'll be talking about both for biomarker and for step therapy. And so we'll be there advocating for our patients and providers and everybody alike this Wednesday. But yeah, watch this space. If you're not already a part of a group that's affiliated with TOPS membership, we do send emails. I know we're trying to make them lean and mean, and also make like some, if you're not interested in the education and outreach, but boy, oh boy, you're interested in advocacy, can we create more tailored messaging so that you can look through, find the signal from the noise?
Right. So my final question, and from your request, things like this, symposiums like this, don't go on without our partners, mainly pharma support. And many times they come to these sessions and they're quiet in the background, mainly because of other restrictions put on them. And they're usually at the tail end of this question. We have their attention, you have their support. How can we utilize pharma in earlier setting, in the screening session, in the transition from one to the other? Is there any role there? And even from anybody from pharma in here, what sort of role do you think you can play? Anybody?
Yeah, please.
Great.
And so every pharma company has an access line, and these are nurse navigators that are helping patients. And my nurse navigator says it doesn't matter what the question is. If they're trying to find something in their area, we're going to try to help them. And so even though it's not directly tied to our drug, if it's, I can't get X, can you give me a service? So I don't know if all access lines do that, but I can certainly take it back to them. Like, what is the need for the access line to grow? So I think there's even just I have a problem and I don't know where to go, or I tried to get this test, I don't know where to go. They help them do that. So there's the piece there. Maybe it needs to be expanded. I know that's just a little piece of the problem.
Go ahead, Joseph. Well, I have some good things and I have some bad things. I'm going to start with the good. The good. And also the good is also bad, but
so you have some bad
coming. Yeah, but good in like, where can we really find alignment of cause with our pharma sponsor? That's the good part. But the problem behind it is coming down the pipeline, as drugs are getting more expensive, there's really two major things coming down that are going to cause some major problems that I see. One is if people fall off Medicaid. And two is even insured patients, if they're getting carved out alternative funding programs where instead of the insurer being the first payment of resort, they become the last. And they basically flip the algorithm to say, even though you're insured, if this is an expensive cancer medicine, we're going to look for the drug manufacturer assistance program first and force you to enroll in that so that the drug company is paying for it. And if you really don't qualify for that, then we'll step in. These are insured patients. I think both of those, both Medicaid maybe being gutted, however you want to phrase that, and the insured patients doing carve-outs specifically around cancer medicines, it's going to put a lot of pressure on pharmaceutical companies and practices to do the right thing and figure out how we're going to pay for that. And some of these things can be fixed, right? We've created these problems. There are ways to uncreate them. And so I think that's a real opportunity to get pharmaceutical companies to say, we need to get as many patients on these drugs that are life extending as possible without sinking the cost on the back end after we've done all the R&D. And if people have insurance, there's a reason why they have insurance. So that's the good side of it. The bad side of it is I don't care how amazing it is for a person to be on Ibrance for 10 years. Most of the drugs, I'm very humble about this, most of the drugs, except for maybe in blood cancers, and even those might be a bridge to allo transplants or cellular therapies, most of the drugs are not curative. And yet the price points and the time on drugs keeps going up and up and up and up and up. And I think there's going to be a real come to Jesus moment about where is the biggest bang for our buck to save lives. And as we start working with primary care and screening, where maybe some of these products become more in the neoadjuvant and adjuvant space, that may not be a huge win for pharmaceutical companies. And yet it could dramatically change the cure rates and curves. So we have to kind of figure out where these priorities are going to be in terms of access to care. Are we giving people so much access that we're actually shifting that staging to 1 and 3 as opposed to 4, which may not open up the pathway for as many drugs, even though the innovation pipeline keeps going down that road.
So I would say part of the issue is not part of just the latter discussion is not a pharma necessarily created problem.
No.
It is, we start from a trialish perspective in the metastatic setting to test those drugs first, partly because those patients are incurable. You want to get them the drug. And then one of the things you don't want to do is make a curable patient incurable from unusual or unnecessary treatment. So that's generally transition. And I will argue that there probably is more money to be made in the adjuvant setting, depending on how long those patients are on drugs, than there is in the metastatic setting. So we have to think about that. Porter, you think you had a comment?
It's well, I do, but it's so much more simple that it really is, because I already said it, and I keep saying it, because see, if I keep saying it, you're gonna remember that I said it. So what can the pharmaceutical companies do? These companies have a stake in getting these patients on therapies, which means getting those patients tested, which means that Genentech and AstraZeneca and all of those companies should pay for the billboards that I mentioned earlier. Why? Because then those patients get tested and they go on that company's drug. So, this is another.
What about paid for the testing because they're going to use your drug?
Right, but well, no, I don't like it, because we heard about the competition within the diagnostic space. It's already too much. And
you can start with an HEOR grant. You can start small scale in a pilot and show proof of principle that it doesn't really eat at your cost to cover those tests. Because if you get more patients on drug, if it pays for itself, we're open for these pilots. It doesn't have to be like, oh, we'll pay for this. That means we're just asking you to pay for more. I even do the same with toxicity management. There's a group of medicines in breast cancer space in the PIK3CA inhibitors. We don't do a good job with insulin. We can treat your nausea until you should never have any vomiting. But if you have a blood sugar of 360, I'm running for the hills. I don't know confidently how to manage that safely, which also happens to be a really high risk factor for acute care utilization. And patients are going to feel crummy. They're going to feel lightheaded. They're not going to stay on that medicine. And then we're scared. And before you know it, we're not prescribing it in the first place, even though it has a really great niche. So hiring a diabetes educator, hiring glucometers that go with these things. There are things that say, hey, if I have a really high grade 3-4 toxicity, that turns out that it's preventing my providers from selecting this for other reasons, not just the genetic component, but the adverse events. Maybe I owe it to them to bundle it in as a part of their treatment.
So I would say a lot of the companies who have these drugs actually do have these programs, maybe not as well known. And maybe that's one of the issues you could do. We're almost to the end, and I'm going to, because she hasn't spoken much, Sonia, any final word?
Thank you, because I want to come back to that too, and to just echo what Jordan said about elevating the primary care and also keeping the communication open, because a lot of patients will come say, okay, when's the last time you saw your PCP? You're my PCP.
Yeah.
And I'm like, I'm not your PCP. And when those blood sugars come and I freak out because I can't remember, I don't even know what drugs now are being treated, or their blood pressure's high. And I'm like, where's your PCP? And that's what they do. And so it's so important to keep that communication open. Make sure you get my note, because I want you to know. I need you. I need you. And so I had a patient the other day, hypertension. I don't know what drugs you start with now. And so it's really important that when we do have some of these toxicities, they're aware of what to expect. They know how to, I'm able to get them back in to see them, pick up the phone, like Jordan said, and just keep that going. And I think that kind of ties in the whole purpose of this conference, right? Is just to how do we continue to communicate with the primary care providers? We have to elevate them because we are not PCPs and they are so much more, they're better at all those other things than we are. And so I think that's.
Can I ask a follow-up question?
Yeah.
So we were talking about, compensation being a part of that. I think, we do a lot of things to our patients that create, that exaggerate their already existing comorbidities or create new side effects and things. And while I absolutely think that, I'm not a primary care doctor or skilled at managing that thing, and that requires skill. So how do we change the nature of that relationship where it doesn't feel like primary care are just picking up all the mess that we're putting on them without necessarily that same level of compensation or support when they're suddenly getting a patient who's far more complex? It still may be blood pressure management. It still may be blood glucose management, but now it's just like, wow, all these things are active issues. All these things are constantly changing issues. There may be more frequent visits necessary for that. I feel like I don't know, to the whole panel, maybe how can we help support primary care to fill that space and feel like they're being elevated?
One is communication, right?
Yes.
And I guess I can even ask you all how you would feel for how you would want us to manage that. Because I know there are some times when the blood sugars get so high that you do want to include the endocrinologist, right? You do want to include some of the drugs I give are cardiotoxic. So I do actually try to be more preventive. And so I do want to include the cardiologist on the up front. So it's not necessarily to step on your toes, but I think just that communication and understanding what to expect would be helpful.
I got a real simple idea. It's almost West specific, so I was just going to hand it.
All right, this is the last comment because
say, as a referring provider, as a courtesy back to her, then you say, thank you so much for referring your patient to West. We want to make sure that you have access to these because we vaccines and who knows where to get
Right.
The vaccine for leading change and leading deprivation. So we get them a portal where they can log in.
Yes.
Patient that's enlisted with them as the referring provider. They can look at that patient up. You won't have access to every patient, but if you are listed as a referring provider, then there's a list of patients that you can see that are in West. And you may open it for once a week and be looking for somebody and say, oh, yeah, this is patient too. Here's this patient. And then all of a sudden, we do
That's cool.
communication. Yeah, so I'm going to give you.
we can do that right now, actually, because some of my referring physicians have access to OngoEMR. And we
Giving
can
you
give
a
you
task.
You're welcome. Yeah, the action plan. You wrote out the action plan.
Thank you, guys. Thank you so very much for showing up.